All right, good afternoon, everyone. Great to see everybody here and spending an hour to talk about sexual trauma and addiction, kind of a heavy topic on a Friday. But want to review a couple of housekeeping things as we get started here. You all are muted. You do not have the option to unmute yourselves. We are recording this so that we can post it for others to see who couldn't be here today. So, so you are muted and you'll remain muted, and your videos are off. Those will stay off for the entirety of the presentation. If you have questions or comments that you would like to share, feel free to put those in the chat box. You do have access to the chat box to ask questions, and I'll try to monitor that as best I can as we move through the presentation today. So we have an hour together, so we're going to get started because this is a lot to cover in such a short period of time. So we will get started. Some objectives we have today are to develop an understanding of the core principles of trauma-informed care, how to apply them to work with substance use clients, definitions of addiction, sexual trauma, and how they impact the brain, and to develop an understanding of the prevalence of sexual trauma and the people that we serve. So let's dive into some stats. So on your screen here are some stats from RAIN, which is an organization, national organization that does a lot of things. And one of the things they do are some gathering statistics. So when you see these stats, these are collected over time. They run kind of regular research projects to get statistics on a variety of things. I recommend you going to their website. They've got stats on all kinds of different populations related to sexual assault in particular. So this is basic stats here. How often does sexual assault occur in the US? Among the inmate population, 80,600 were sexually assaulted or raped. Children, 60,000. General public, and that's Americans 12 and older who were sexually assaulted or raped, is 433,648, pretty big number. And then in the military, 18,900 experienced unwanted sexual contact. So as you can see, this is a pretty prevalent issue in our society. And everyone's affected. So taking a look at some more stats, again, these are all from RAIN, these stats. So about every 68 seconds, an American is sexually assaulted. 1 out of every 6 American women has been the victim of an attempted or completed rape in their lifetime. About 3% of American men, or 1 in 33, have experienced an attempted or completed rape in their lifetime. And then from the time span of 2009 to 2013, so this is a little dated, this stat, but Child Protective Service agencies substantiated or found strong evidence to indicate that 63,000 children a year were victims of sexual abuse. And a majority of child victims are ages 12 to 17. Of victims under the age of 18, 34% of victims of sexual assault and rape are under the age of 12, and 66% of victims are the age range of 12 to 17. So again, very prevalent. We have all experienced some level of effects from sexual violence. And then kind of to extrapolate this to substance use, people who have been sexually assaulted are more likely to use drugs than the general public. They're 3.4 times more likely to use marijuana, 6 times more likely to use cocaine, and 10 times more likely to use other major drugs. So again, that gives you a snapshot, and RAIN is always updating these stats. So they're changing as they gather more evidence. So it's a nice website to take a look at to see the trends nationally of what's going on. There's also a state-by-state look at the laws around sexual violence and what is considered a crime and the definitions of that on the RAIN website. So in Louisiana, we have lots of laws related to sexual violence. And so you can read kind of the definition and what's considered battery versus, other types of sexual assault. You can kind of compare and contrast. It's a long list of the different crimes and laws. So that's something we couldn't cover in the time we have allotted today, but that's a great resource to look state by state at what's considered various types of sexual violence and how those are prosecuted, what the sentences could be for those things, and what the laws actually say. So that's a great resource, this website, to take a look at. So what's the definition of sexual trauma? So let's break this down just a little bit into a couple different areas. So number one, there's sexual violence. And you can think of sexual violence as a very big umbrella term. So it's all encompassing, it's not a legal term, and it refers to crimes like sexual assault, rape, and sexual abuse. But many of these types of crimes have different definitions in terms of the law. So it's not a legal definition, and these various crimes can have very different definitions from state to state, depending on how they're legally defined. But you can think of kind of a bunch of little subheadings underneath sexual violence. So we could be talking about stalking, we could be talking about intimate partner violence, sexual harassment, incest, child sexual abuse, sex trafficking, technology-based sexual exploitation, which is a kind of a big thing nowadays with social media and our use of internet for pretty much everything we do nowadays. Elder abuse, military sexual trauma, and there's many more. That's just a kind of sampling of some of the terms that you might hear when we're talking about sexual violence. So when does that become trauma? There's kind of the sexual violence, which is more of, an act, a behavior, or a crime. And then sexual trauma is the exposure a person has to any sexually inappropriate behaviors that cause a person to experience a great deal of stress. Now that it's a little bit subjective there in terms of what a great deal of stress means, but typically the exposure happens without consent or when a person is not able to give free consent. For example, they might be intoxicated or impaired in some way. And then the related distress that a person feels is often in the form of increased fear, anxiety, or depression. It's kind of the common ones I think we see, although not everyone responds to stress or trauma the same way. So some people might be deeply affected, and others may seemingly not be as affected. And so that's a very subjective experience for an individual who's experienced some type of sexual trauma. Their distress can look very different from person to person. So, and then clinically, we have a diagnosis of post-traumatic stress disorder. So PTSD is really diagnosed when there's a pattern of symptoms that are in response to the trauma that has occurred, in this case, the sexual trauma. So some of those symptoms involve intrusive and vivid flashbacks, thoughts, dreams related to the trauma, things like that. Number two, avoidance or a numbing associated with reminders such as people, places, objects, things, stuff like that. And then third, there's functional responses such as poor coordination. They might have memory gaps. They might have a startle response, be jumpy or hypervigilant. That's not all the diagnostic criteria associated with PTSD, but kind of the major points there that someone might be experiencing that we would label as PTSD. And this is also PTSD, there's a time element. So when we're diagnosing somebody with PTSD, this is that these symptoms have persisted long after the trauma was experienced. So we kind of expect somebody to have these kinds of symptoms right after a trauma happens. But if these things are still persisting to a level of distress for long periods of time, that's when we're looking at a PTSD diagnosis. So there's some time that needs to be there post the sexual trauma experience, and that this pattern is continuing of all of these symptoms, and that it's causing distress. Okay, so that's kind of where we've gotten from the sexual violence to sexual trauma to when we look at PTSD. So those are some terms defined. So let's flip over and talk about addiction. So this is a definition from NIDA, the National Institute on Drug Abuse, that addiction is defined as a chronic relapsing brain disease that's characterized by compulsive drug seeking and use despite harmful consequences. It's considered a brain disease because drugs change the brain. They change the structure and how it works of the brain they're talking about. So looking at how addiction occurs, and specifically talking about substance use, that when you introduce a chemical into your body, it's inevitably going to have some impact on not just your organ functions, but also your brain functions. But also trauma impacts the brain, and we're going to take a look at that. So when we have someone with both a trauma and an addiction that are both impacting the brain, when we're looking at how we work with that person in treatment, whether we're doing mental health treatment or substance use treatment or doing an integration of those in our treatment program, we need to really pay attention to both sides of how the addiction is functioning as well as how the trauma is functioning. So we're going to talk towards the end of this presentation about what this means for the kind of treatment we provide in our programs or in our counseling services that we provide. So let's look at the brain. Okay, so taking a look at this model here, this is a neuron. And so we got a neuron up here and we got a neuron down below, and they're going to talk to each other. And this is how we communicate messages throughout our brain, is this space in between called the synapse. So here we're looking at how cocaine impacts the brain. So you can see these little black bars here in the synapse are cocaine, okay? And what's happening is specifically we're looking at the neurotransmitter of dopamine. So we've got dopamine up here in this neuron at the top, and it's all in these little bubbles, all the dopamines just floating around in this neuron. And we need to, and it's communicating with this neuron down here that's receiving the message. So the neuron at the top is releasing dopamine into the synapse, and you can see all the little bubbles of the dopamine being released. And to your, I think it would be the left of your screen, you see the dopamine transporter here that is releasing the dopamine into the synapse, and that's functioning normally. But when we introduce cocaine, to the right of your screen, you see that that transporter is being blocked by the cocaine. So it's not allowing the dopamine, oops, click the wrong button. Whoops, geez. Okay, so it's not allowing the dopamine to be released into the synapse. And then these receptors down here that are receiving the dopamine are not able to receive as much dopamine. So this dopamine out here in the synapse is just kind of hanging out. And then it's also being blocked. The cocaine is blocking the dopamine from being released from this neuron up top. So it's kind of collecting in this neuron up here. So you can see that cocaine is directly impacting how neurons communicate with each other in the brain. And it's impacting specifically for cocaine, dopamine. Other drugs might act on other neurotransmitters besides dopamine, and they may function a little bit differently. Sometimes we have drugs sitting on these receptors down here. Other times we have drugs blocking, like dopamine is, or like the cocaine one is here. So we can see that functionally, any introduction of a substance into our brain, it is causing these neurons to communicate differently. It might be stunting their communication. It might be making them communicate more rapidly. It may be flooding these receptors or flooding the synapse. There's all kinds of things that happen with substances. This is just an example of cocaine. So keeping that in mind as we move forward, that functionally, if we have somebody that's using cocaine, for example, for long periods of time, basically the cocaine is training the brain to function differently. And so when someone enters into treatment and we take, the cocaine is taken away, then the brain kind of has an adjustment process or a relearning process to learn how to function independent of the cocaine. And sometimes that can take quite a while. And we know that those of us who've worked in the treatment field kind of know that the first little while somebody's engaging in sobriety, that it may take a little while for them to feel quote unquote normal again, or for their brain to kind of come out of the fog and learn how to function independent of the substance and whatever the substance was doing in the brain. So let's take a look at normal brain function prior to substance use, and then after substance use is on the right of your screen. So you can see that there's these different aspects of the brain. We've got some executive functioning and inhibitory control up at the top in the blue. Then there's motivation and drive in this area, the green. We have the reward system right here in the middle in the red. And then we have memory and learning, which is the purple. So you can see all these different areas of the brain and how they're communicating with each other. So we got the executive function and the inhibitory control communicating directly with motivation and drive. We've got kind of this reward system communicating with everybody. And you can see that it's functioning normally. And then after substance use on the right side of your screen, there's kind of a hijacking that occurs. And the reward system and the pleasure-seeking area of the brain is kind of hijacking everywhere else and taking over. And that's the primary mode of communication, where this reward system is kind of communicating to everything else and overriding some of this executive function, this inhibitory control, and the motivation and drive, and then the memory and learning. So what happens is when there's, over here on the left, before the substance use, we have strong connections between judgment and motivation right here, this executive function, inhibitory control, and the motivation and drive area. But after substance use, you can see this arrow is very, very tiny now, because the pleasure seeking of the substance use really overrides those connections. And, people make maybe poor decisions. They do things and say things that they may not do when they were sober. And so this pleasure-seeking element and reward system really takes over all those other functionings in the brain. So hijacking their judgment and inhibitory control in particular. So then we include some trauma elements. So we talked about trauma in general, and perhaps you're familiar with the ACEs, or the adverse childhood experiences. It's been around for a while now, but basically there's a 10-question survey or inventory that you can take that gives you a score, and any yes answer equals 1 point. So this is you can read through this if you haven't seen it before. These are the questions, and it's prior to your 18th birthday. Did any of these things happen to you, or did you experience any of these things? And every yes answer gives you 1 point. And then basically you add up the points at the end, and that's your ACEs score. So it's out of 10. You can have 10 or 0 or any number in between. So what's been found through this research on adverse childhood experiences is that it has implications and puts people at higher risk for different things happening as adults. So let's take a look at some of those. So remember, there's the score. So some people might have experienced no adverse childhood experiences, and this scale goes up to 4 or more. So you can kind of see the breakdown among binary genders of women and men. There's approximately 34.5% of women have 0, 1, and it goes from there up to 4. Same thing for men. And then the total for both genders is kind of the average over here. So you can see that a lot of the population is experiencing some adverse childhood experiences. So, 34.5 might be experience none, but then there's a lot of people that are experiencing 1 or more. So what does that really mean? This is another, before we get to what that means, this is another breakdown of just the different areas from the ACE questionnaire of, I don't know why that keeps going back. I don't think I'm pressing anything. But looking at the recurrent and severe physical abuse, about 11% of people have experienced that one prior to their 18th birthday. Emotional abuse, same, about 11%. Contact sexual abuse. So now we've jumped to double, it's 22%. So when we're talking about sexual abuse or sexual violence and trauma that someone might have experienced, that's, pulling out from the ACEs, about 22% of people have experienced that. That's a pretty high number of people that have experienced that prior to their 18th birthday. Almost a quarter of the population, which would be 25%. People growing up with an alcohol or drug user in their house, 24%. Growing up with a family member in prison, 3%. Family member with mental illness, 9%. Growing up seeing your mother being treated violently, 12%. Growing up with both parents not being present, 22%. So now we get to what this means and what it means specifically related to addiction. What they found through everyone who's taken the ACEs inventory, that women were 50% more likely than men to have experienced 5 or more adverse childhood experiences. And the higher the ACE score, the higher the chances of addiction to alcohol and other drugs in adulthood. So people that had a 4 or more ACE score had a 500% increase in risk for adult alcoholism. Men in particular with 6 or more ACEs was a 4,600% increase in risk for IV drug use in particular. And then 78% of IV drug use in women can be attributed to adverse childhood experiences, which includes sexual abuse. So there's a lot of correlation between the ACEs, adverse childhood experiences, and creating or being at higher risk for addiction as an adult. And so basically what we can glean from this in a larger scale is that there's a good chance that our clients that we see in addiction treatment programs have some type of trauma and probably an adverse childhood experience of at least 1 in their past. And there's some, perhaps there's some need to help them deal with the trauma as well as their addiction in an integrated manner. So some treatment programs have started giving the ACEs inventory to their new admissions to kind of assess what are some of those things from childhood that may need to be addressed in treatment, as well, in addition to the addiction. But also there's this element that an environment matters. So this guy, Dr. Vince Folletti, he's the one who spearheaded the ACEs and created and started doing all this research on ACEs. And he basically said that in relation to addiction, that our findings are disturbing to some because they imply that the basic causes of addiction lie within us and the way that we treat each other, not necessarily in drug dealers and dangerous chemicals being out on the streets. So we've spent a lot of money, in his opinion, everywhere, like on drug dealers or dangerous chemicals and things like that, except for where perhaps some of the answer is to be found, which is in the environments that people grow up in or are still exposed to. So looking, and I think we know a lot of this in our addiction work in general, is that environment matters. Where somebody lives, what influences they have on a day-to-day basis, whether it be from childhood or currently, the people that they spend their time with, how those people are an influence to them, or how they might be in a toxic or abusive relationship and the implications that has for addiction and continued addiction in particular. So in essence, it's not just when we're dealing with addiction treatment and what we do in our programs, it's not just about the chemicals that they're putting into their body, but all these other factors and environmental factors, including trauma, that we need to pay attention to as well. And I think it's really safe to assume at this point that most people that have an addiction have experienced some form of trauma. It may not all be sexual trauma like we're talking about today, but that we really do need to look at people from a more trauma-informed perspective. And so that's what we're going to kind of shift to a little bit momentarily. But before we get there, I want to take a look at, all those elements of the brain that we talked about how addiction impacts. This is how trauma impacts. And you can see it's pretty much the same areas. It's the prefrontal cortex, which has to do with our executive functioning, our motivation and drive, our decision-making, all that good stuff, behavior regulation, problem solving. Then we have the amygdala and hippocampus, which also the amygdala participates in decision-making, regulates behavior, and initiates our fear response. The hippocampus has to do more with memory and learning. And so all of those areas are impacted and affected by specifically PTSD. So if we have somebody that has a diagnosis of PTSD coming into our programs, then their brain has been affected in a double capacity, really, from their addiction as well as the trauma that they experienced. And I think we can really extrapolate this to clients that have experienced trauma, even if it doesn't necessarily rise to the level of PTSD. They may not meet that diagnostic criteria, but we know that trauma affects these areas of the brain, which are the same areas that substance use impacts and addiction impacts. So they kind of have a double whammy. When someone comes in for substance use treatment and they have a trauma history, those parts of their brain have been impacted by both issues. So we need to take a look at that and pay attention to that as we're working with them in our treatment programs. And just to throw this in there as, gosh, why does this keep going forward? Simple versus complex PTSD. I think these terms are kind of thrown around a little bit. So just to clarify, that simple PTSD is typically a response to one incident that's usually experienced as an adult. That's a little bit of a generalization. That's not always the way it happens, but usually it's one incident that has happened. And then complex PTSD is associated with more repeated incidents, which don't have to be the same incident over and over again, but it can be multiple abusive or violent incidents that happen over and over again. So things are a little bit more layered and complex. And you can see the symptomology that's more broad when it comes to complex PTSD, just because they've had repeated incidents over and over again. There tends to be more self-harm, suicide, dissociation, problems with relationships, memory, sexuality, health, anger, shame, guilt, numbness, loss of faith and trust, and feeling like they're damaged goods. So even within the diagnosis of PTSD, things can get a little bit more complicated when we're working with somebody who has complex PTSD as well as an addiction. It just has a little bit broader implications, and there may be a little bit more longer term treatment that we would need to do with that person, just because of the layers of trauma they've experienced and how that impacts things. Okay, so I mentioned trauma-informed treatment. And what does that really look like is what we're going to talk about for the last half of this presentation. And really, when it comes down to it, it requires us to sort of shift the way we look at addiction treatment away from a more traditional approach toward one that seeks to reflect the principles of trauma-informed care, which basically just takes into account that most of our clients have experienced some level of trauma, and that's a component that needs to be addressed in the addiction treatment program. So there's this integration approach that needs to happen, and that we can't treat it in a silo, which may have been the traditional approach where we treat the addiction only, and then someone else, you know, a mental health provider would treat the trauma. And really, because both of those things influence each other, like we've just been talking about, that we can't ignore the other one. So we really need to pay attention to working with someone from both those areas of the trauma needs to be addressed, as well as the addiction components need to be addressed. Okay, so here's the trauma-informed principles, or the principles of trauma-informed care. So we've got the things across the top, the principles themselves, and then some definitions and how this might look in practice, or what we need to pay attention to in practice. So we've got safety, choice, collaboration, trustworthiness, and empowerment as our principles. So looking at the definition of safety, it's looking at physical and emotional safety of this person that we're treating. So in our treatment programs, what we can pay attention to is the safety around our common areas. Are they welcoming? Is there privacy? Is there privacy in our group rooms, in our individual counseling rooms, or in our spaces where clients might be seeing doctors or other types of clinicians? Are those areas not just welcoming, but do they feel safe? So for example, having in your waiting room, having lots of windows that can be seen, you know, by the street or by passersby, someone may not feel safe because a person, you know, someone from outside that's just walking down the street or driving down the street could see them, that they're sitting in a waiting room at a clinic. So paying attention to stuff like that. Is there, what's the color on the walls? What's the type of furniture? You know, some of that you may or may not have much control over, but kind of thinking through those things, how can you make it more inviting and comfortable? Maybe just putting pillows on the couch, or having some soothing type of music playing in the waiting room could be helpful, or an added benefit to make somebody feel safe and calm. Things like your check-in process. So when a client comes into the waiting room and they check in with the front desk or with whoever, however that process works, is that respecting privacy, or are their names being yelled out into the waiting room? Things like that that might make somebody feel less safe in that space. So it can be kind of processes, and also the physical space and how it flows and functions to respect privacy and to be welcoming. So the next principle has to do with choice, that the person being treated has choice and control. So what does this look like, and what could you take a look at procedurally that gives an individual choice and control? Are they communicated with in a way that they understand their rights and responsibilities as a client? Do they understand the consequences for things that they might do in the treatment program? You know, so if they break a rule, for example, or what are the rules? And if they break them, what are the consequences? And are there rules that kind of have higher consequences than others? Talking to them about that. If they have a choice about the type of clinician that they see, or the composition of their treatment team, then, you know, like if you have a variety of counselors and you have maybe counselors that specialize in different things, or counselors that have different attributes that may be a comfort to your particular client. So asking what their preferences are. Some some of your treatment programs, you may not have that option to give clients a choice around what clinician they see. But if you do, or if there's a way that you can provide choice a little bit more in your processes and procedures, then that can help somebody feel safe and feel like they're a part of this process and that they have more control. And when you think about someone who's been through trauma, they often feel like they don't have control and didn't have control in the episode of trauma that they experienced. So whatever that sexual assault was or sexual violence that they experienced was, they didn't feel like they had a choice and didn't feel safe. So again, in our treatment programs, taking a look at our processes and procedures to see how we can include more choice so they feel like they have a little bit more control. Next is collaboration. So making decisions with the client and sharing power. So there's kind of a power differential that's just inherent in our treatment programs and in us as counselors and healthcare providers, that we have more power than the client, particularly if they are a mandated client. So they're mandated to our treatment program for some reason. Then, they might really feel disempowered and that they're not really a part of the decision-making. They're not a part of their choices. They're not in control of those choices because someone else is making decisions for them. So as much as we can include them in planning services, give them opportunities to provide feedback about services can be really helpful so that they have a voice, but also not just receiving the information from the client. For example, if they fill out a comment card or they're, are bringing you kind of a grievance or a complaint, but what are we doing with that information? So it's not just falling on deaf ears, but demonstrating that we as counselors or treatment providers are really listening and hearing their feedback. So that might go towards your, how you get feedback from your clients, whether it's a, comment suggestion box, or if you periodically do kind of satisfaction surveys or things like that in your program. So making sure clients are aware that these are the avenues that they can give you feedback and that you encourage it. And then in the treatment planning process is probably the biggest place that we can offer clients that collaboration in terms of what are their treatment goals? What do they really want to work on through their participation in our services? And making sure that they're a major part of that, of designing what their treatment goals are. The next principle is trustworthiness. So kind of demonstrating to clients that they can trust us, that there's clarity in their tasks, consistency in our interactions with our clients, and that interpersonal boundaries are maintained. So, how do we show our clients respect? Are we treating all clients with respect and in the same way? How do we manage professional boundaries? So making sure that we don't allow one client to kind of get away with something that we wouldn't allow another client to get away from. Are we, giving, showing favoritism in some way? If our clients are contacting us after hours, for example, and we set a boundary where you can contact me up until 6 p.m. and then you need to contact this other person or this other resource, then that's what we do for everybody, all of our clients, that we're maintaining professional boundaries across the board. And that demonstrates that the client can trust us, that we're being consistent, and that we treat everybody with respect and with the same level of boundaries. And the last one is around empowerment. So clients that have been traumatized are often feeling pretty disempowered and, are lacking a lot of skills. So providing an atmosphere that allows the clients we serve to feel validated and affirmed with each contact with the agency. So that's, from the people that answer the phones to the clinical staff, to the medical staff, and kind of anyone else in between, the maintenance people that come in and service the building, that clients are having a positive experience across the board. And that you, again, may or may not have much control over all of those things, but taking a look at processes, giving feedback to, your superiors or supervisors around areas where these principles could be enhanced, and also areas where it's kind of directly opposed to or going away from these type of principles, is important to take a look at too. So are there kind of processes or procedures that are taking away client choice, taking away that collaboration or empowerment or safety, as well as where are we doing well? And maybe we can enhance a few things. So taking a look kind of across your treatment program, not just from the clinical programmatic pieces or the specific counseling interventions, but across the program in all of the processes and how a client interacts with your agency, and taking a look at these 5 principles and seeing where maybe we could do some things better, because we recognize that we do have a lot of individuals that come through that have trauma and may not feel safe. So what can we do to help them feel, to have positive interactions, but also to feel like they're a part of the process and they're a part of their treatment? So how can addiction treatment be re-traumatizing? And this is kind of stuff we might want to avoid. So looking at the concept of powerlessness is kind of the opposite of empowerment in a lot of ways. So, that they were powerless to do something may really work well in talking about addiction, doesn't work so well in talking about sexual trauma. And so how can we kind of bridge the gap there? Because we really, from a trauma-informed approach, want to increase empowerment. And so perhaps the concept of powerlessness may not be very helpful, and we may need to frame that concept in a little bit of a different way, because we're taking into account the trauma that they've experienced. This speaks to collaboration, but that us as counselors are not the absolute authority. And sometimes that's been the case in some traditional treatment programs where me as the counselor, I'm telling you what to do all these things. But again, that's taking away the collaboration from the client, their ability to exert some control in their lives. And so that piece of collaboration where we're bringing the client in to talk, to be a part of the treatment program or be a part of their treatment planning, whatever we can give them choice about and a say in, is going to be inclusive of the trauma they've experienced and not just telling them what to do all the time. Confrontation may be very triggering for clients that have experienced trauma. And so we may take a look at some of the processes in our treatment program that may be very confrontational. There's a lot of elements of traditional addiction treatment that have some confrontation elements. Like an example would be an intervention where you put a client in the middle of the group in a chair, and the group members give them feedback, which can be kind of negative or positive. Those kinds of things where somebody's put on the spot in the middle and like feeling like they're attacked by the other group members can be traumatizing for a client who's experienced trauma, and can be very triggering. And so those types of interventions are probably not the best interventions for a client who's experienced significant trauma, particularly of a sexual nature as well. Anything that's going to shame the client or increase shame, most clients that have experienced sexual trauma already feel a high level of shame because of the trauma experience they had. And so anything that would be an exercise or a group process or intervention that might cause additional shame can be very triggering and not beneficial therapeutically for a client who's experienced trauma. A focus on character defects, which, this is a 12-step term, of character defects, while that might be really effective working with addiction solely, with clients that have had trauma, the concept of character defects can give the impression that there's things that are broken or defective about them. And already they're feeling that because they feel that as a response to the trauma that they experienced. So again, this is kind of where terminology makes a difference. You know, it's like we might just switch that term from character defects to this is something that you struggle with, or this is something that has been a challenge for you. Instead of using that term character defect, because it kind of gives that message that there's something defective or wrong and that can't be fixed, or is just makes them kind of damaged goods. So again, you know, kind of a shift in language there, but can be pretty powerful. The concept that people with addictions can't be trusted to tell the truth and that they're lying. So, you know, clients that have experienced sexual trauma in particular have often had a very hard time telling people that they even experienced the sexual trauma. It's a source of shame. They feel, you know, like people won't believe them. And so then we add on this concept of, well, you're an addict, so you can't be trusted as well. Again, kind of the language issue and the giving them the message that you're damaged goods and that there's these things that are just inherent in who you are. So kind of getting away from those gross generalizations or stigmatizing type of language. This is a tricky one, discharges for non-compliance. You know, those of you that work in treatment programs that kind of have rules and boundaries around them, and for good reason, any violation of those rules or boundaries might result in a discharge for non-compliance. You know, because they're not following the rules or engaging in whatever milestones they might need to engage in to work through the program successfully. But what happens for someone who's experienced trauma is that some things can be pretty triggering or really difficult for them. So there might be some milestones or some, you know, assignments or things in a treatment program that they might need to do that may be very triggering for them. And so, or they might have a really hard time following some of the rules, or they may have a triggering episode, like if another client, like let's say you have a residential program or even an outpatient IOP type program, that a client is saying, you know, one client says maybe a comment to another client, and the client receiving the comment, that's triggering for them. And so they respond in a very aggressive manner. So if they respond in an aggressive manner, that might be kind of violating a rule. They may need to have some consequences or something like that in terms of being able to continue in the treatment program. But that gets tricky because now we've just discharged somebody for, you know, a trigger response based on trauma. And so what can we do to kind of work with clients in those scenarios and recognize that they might have been triggered? And so that's why they reacted. It activated their fight or flight response. And is there something that we can do about that and to keep them in treatment? Or perhaps get them connected to another treatment program that might be a better fit for them based on those issues. So maybe your treatment program can't accommodate it, but how can we get them connected elsewhere? But that can get tricky because we have rules for good reason and we got to maintain the safety. So that can be a very hard one, especially in the context of residential treatment programs where clients are living there. And you kind of got to manage the community of clients living in the same space. This one kind of goes to in the same vein of punishing aggression in particular. And aggression is often a response to the fight or flight system being activated based on a trauma response. So is there something we can do to kind of work with that client on their aggression and on that trigger response, but also recognizing that maybe there are some rules around aggression, and depending on how aggressive they were, we may or may not be able to work with that within the treatment program and the confines of the treatment program. But, as much as we can, recognizing that as a trauma response, and how do we kind of de-escalate from that and teach them some skills to kind of manage that trigger response in the future. We talked about this one already, but not giving clients a choice can be traumatizing to them, and we can that can activate some really negative behaviors that are problematic, and again, responses to a trigger of them not having choice or not having control, and that harkens back to the trauma as well. Withholding medication-assisted treatment, which some clients really need medications to help them manage their trauma responses or symptomology around trauma, and then also for the addiction side of things, helping them get connected to some medication-assisted treatment can be really helpful. Okay, so these are some things to move away from kind of in the traditional experience of substance use treatment on the left side, where there might be some elements of punishment in a treatment program. There may be some distrust of the client, that they're not telling the truth or things like that, confrontation tactics, authoritative, telling clients what to do and maintaining compliance, and instead kind of shifting to more of these trauma-informed concepts of safety, trust, collaboration, choice, and treatment empowerment, and then hopefully transformation, ultimately, that they're changing their lives and becoming healthier. Okay, so a lot of treatment programs, in an effort to be more trauma-informed, are incorporating DBT, or dialectical behavior therapy, which has these 4 components to it, of mindfulness, emotional regulation, distress tolerance, and interpersonal effectiveness. And these can be really helpful because they're skills. It comes from cognitive behavioral therapy, but kind of a subset of that. And as many of you probably know, DBT was originally centered around working with clients with personality disorders, but it's really effective working with clients with trauma history, which we know a lot of people with personality disorders also have a trauma history. So in our addiction treatment program, since most of our clients have a trauma history, whether it's sexual trauma or otherwise, we can utilize these skills and teach them these skills to help them work through their trigger responses that's activating their fight or flight system, managing situations that might be triggering for them from a crisis perspective, and then teaching them how to communicate better and have more healthy relationships that are, not as toxic perhaps in the past. So that can be a really great tool. If you're not familiar with DBT, I would suggest you go to a DBT training or just Google and get some information, because these skills can be really helpful to incorporate into your treatment program. And the other things, what we know also is that trauma is stored in the body, and there are these physiological responses that people have when they experience a trigger from trauma, and this fight or flight system that gets activated. You can see through this visual here all the different things that happens within somebody's body when they're triggered and activated. And so those DBT skills can help reduce some of these responses in the moment, like the mindfulness activities and the distress tolerance type of stuff and emotional regulation. But what we know too is that clients who've had trauma tend to develop these kind of cover stories to explain away their symptoms and behaviors. And that when they have, nobody likes to feel activated in these ways, where our heart's racing, or we're sweating, our muscles are tense for action, shallow breathing, all these things. That's not really pleasant. And so oftentimes clients will kind of develop or minimize and develop these kind of cover stories that, oh, that just happens sometimes, or oh, I just was really hot. I just raced to get in here, kind of thing. But when those things happen with a client, that should be kind of a clue to us that this is a client that may have experienced trauma, and they may be having a physiological response to something that's a trigger in their environment, and we need to take that into account. So there's some things that we can do to work with the body, and a lot of mindfulness exercises are, things like breathing and visualizations and stuff like that, that can really help a client regulate their body, but also regulate that physiological response to trauma. So things like working through breathing, or maybe movement like yoga, things like that, some touch or rhythm. And we'll talk about these in just a few minutes. But movement-oriented activities with somebody with trauma should be more of a priority than maybe just a kind of adjunctive therapy. So like if you have a yoga group, for example, like you can do chair yoga as an example. So, that should be kind of a more primary intervention or a priority of a group for a client to attend that has a trauma history, particularly sexual trauma, because it helps them become more in tune with their body. And that's part of a lot of the challenge with somebody who's experienced sexual trauma in particular, is that they might have more responses to physical touch or be triggered, or they have more kind of body related issues like trouble having sex or engaging in intimacy with somebody, or just kind of a negative body image perception and things like that. So doing some movement oriented activities and mindfulness techniques can really help somebody who's experienced sexual trauma in particular. And then once the body kind of settles down, then we can begin to work through more of the emotional and cognitive elements of trauma and help them heal that way. So that's why those, again, going back to the DBT, those kinds of skills can be really helpful. And there's a bunch of body-based interventions that you may be interested in and want to explore and get more information about. Like I mentioned, yoga, you can do art, music, movement, like the yoga practices and things like that, Tai Chi, stuff like that. Equine therapy can be really helpful. Drumming and sound healing, which the drumming can include clients with drums, or kind of listening to drumming happening. We talked about the mindfulness, breathing, meditation, visualization, EMDR, eye movement desensitization and reprocessing. Also, there's a similar technique called brain spotting that can be helpful to work through trauma. Also, things that you may or may not think about all the time, like theater, improv, or psychodrama. Incorporating some psychodrama into your practice or your treatment program can be an experiential way for somebody physically to work through some trauma, as well as the addiction side. Things that are sensory motor techniques like SMART, sensory motor psychotherapy, or somatic re-experiencing can be helpful, and things that you would need to get training on to be able to implement. Other things like neurofeedback, Reiki, tapping, AIT, acupuncture, massage therapy, all of these things could be things that could really help a client work through some of the psychosomatic responses to trauma and to triggering that they might experience in their environment. So for clients that are in your treatment programs that have sexual trauma in particular, any of these interventions can be helpful, but also it'd be about catering to the unique experience of that client and what their comfort level is, because some things that involve touching them, they may not feel as comfortable with, or you might have to work up to things like that, just because the trauma involved touch. So, being mindful of those kinds of things with your client and exploring what are some other, body-based type of interventions like these on this list that could be helpful for a client and catering to whatever their needs are. So this is where we can really do a nice job of individualizing the treatment for a particular client. And even if our treatment program can't provide some of these things, we could certainly refer clients to other treatment programs or other just community providers that do these types of things. But I really encourage you to take a look at some of these things. If you haven't heard of them, then jot them down and Google them later and get familiar with them, because they can really be nice integrated therapies to what you're providing in your treatment program and ultimately really help a client out. So that's the end. I know we're 1 minute over, so thank you so much for being here today and participating. You will get an email with a link to a survey that has a couple of little questions just to test your knowledge on where you're paying attention and some feedback about your satisfaction with this webinar. Once you complete that, then you will be emailed your, or you will have access to your certificate for your continuing education. So thank you so much. It'll be sent to you in about 5 minutes. So be on the lookout for that email. And I look forward to seeing some of you, hopefully, in future webinars. So have a wonderful weekend. Thanks again for being here. Bye-bye.